You guys got it?
Yep. Is that all set, Sheila?
Yep, perfect.
Okay. Should we start?
You are all set.
Okay, great. Welcome everybody. So today we're going to talk about kind of what happens to people with Angelman syndrome as they hit adulthood. There's really not a lot in the literature. There's not a lot known, but as folks are getting older, we're seeing more and more, and we're kind of learning more and more as we go. And so kind of what we're seeing now is that the first generation of children that were diagnosed with Angelman syndrome back in the 80s and 90s are now finally becoming adults. So that's kind of why we're seeing more adults and really seeing more, learning more. And the number of adults with Angelman syndrome now continues to grow. But like I said, there's very little in the literature regarding this, and just very little out there in terms of information. So that's why we're trying to kind of seek out more knowledge and learn more as we go. Another big issue for adults is that adult specialists who don't have experience with not only Angelman syndrome but developmental disabilities in general. Um, so just here in our clinic here at Mass General Hospital, what we have is a multidisciplinary clinic for all ages. So we see babies all the way up to however old. So far, the oldest folks we've seen have been in their 40s. And we have neurology/epilepsy, so that's pretty much me. That's what I do. And then we also have psychiatrists, neuropsychologists, GI doctors, sleep specialists, geneticists if needed. And what our clinic includes is an adult program at the Lurie Center. So the Lurie Center is Mass General's autism/developmental disability center, and they already have a built-in adult program for folks with autism and developmental disabilities that was kind of started as part of the whole Lurie Center foundation when it all began. So we kind of use those resources to help people when kids turn 18 and they need to do guardianship, when people turn 22 and age out of the school system. And so it's really not just purely medical, but also the whole kind of social aspect of it too, because there's big changes at 18 and at 22, and kind of life changes because you don't get the same services and the same programs that you do when people are younger. So far, we've seen close to 140 individuals now with Angelman syndrome, and of the first 130, we saw 48 were age 13 and over, so about a little over 1/3 of the folks who'd seen it were 13 and over. And the percentage of individuals beyond puberty continues to increase every year, so every year we're seeing more and more teens and adults. I'll turn it over to Dr. Larson.
So we did a study looking at many individuals who were 16 years of age and older. We did a series of phone interviews. Some of you who participated may be joining us, and we feel so incredibly grateful to those who participated. We interviewed caregivers for those individuals and looked at areas of health and wellness, seizure control, sleep, as well as communication and mobility. And we'll sort of go through some of these data to help us understand more about where individuals are as they age and what are the primary things that are sort of affecting their health and wellness. So for this study, again, it was for individuals 16 years of age and older. We had all the way to age 50. We had about a 50-50 split between men and women who were a part of the series. The majority of the interviewees, the people that we also had some fathers and then other caregivers. The genotype profile for the patient study, cohort study, was consistent with what we see in the general population, relatively similar. And 3/4 of individuals were living in parents' homes at the time that the study was done. So we focused, one of our primary areas of interest is understanding what happens with age for individuals with Angelman syndrome and their seizures. We found that 60% of those enrolled in the study were seizure-free, but as you can see from this slide, the majority, or just under half, continue to be on anti-epileptic medications, AEDs. We also looked at those with active seizures, how many of them were having more than one type of seizure, and actually it was relatively limited, with only 12% over having more than one type of seizure. As we monitor seizures, of course, you think about how long the episode is lasting. You also think about how frequently it's happening. And looking at this adult group, we saw that only 16% were having active daily seizures. And because it was an interview series, a phone interview, we weren't able to evaluate EEG data. So sort of when a patient would have electrodes on their head and we'd look at the brain waves to sort of confirm a seizure. We didn't have those data. We just had sort of what the parent or the caregiver was seeing as consistent with a seizure. But that was much more information than we've had previously, and so was helpful. As we look at sort of what might be happening over an individual's lifetime, the vast majority of caregivers described that the seizures were most severe, either the sort of most detrimental to the quality of life or the most frequent in early childhood. And this is consistent with what we've seen clinically, but with 3/4 of the cohort having their most severe seizures at age 10 or younger. However, we did see that at later ages, a subset of the patient population were describing as having ongoing severe seizures. When we think about what medications this patient group is on, as we would somewhat expect, the majority were on Depakote or valproic acid. And then a smaller proportion were on some of the newer agents, lamotrigine and levetiracetam, as well as clonazepam.
Oh, great. And so just to kind of compare that to the larger survey that we did back in, actually did back in 07, but finally published in 09, we did a survey that actually many of you may have taken part in, so again, thank you. And we actually got responses. It was an online survey through the Angelman Syndrome Foundation, and we actually got 461 responses. So what we found is that 86% had experienced seizures, and this was of all ages, and that 60% had one or more seizure type. And looking at the medicines, again, valproic acid or Depakote was the most commonly used, followed by clonazepam, so very similar results that we found as to what we found in the adult study, looking at kind of all ages. And actually, let me kind of skip to the more interesting stuff. So so typically that's what we see looking back at what people have been on, what people have been using, but that's not exactly what we recommend so much. What I recommend so much as medicine. So kind of the more people we see, the more people we treat. I've been transitioning more and more adults off of Depakote onto newer medicines like clobazam, Keppra, and Lamictal. And just to kind of look at it more scientifically, what we did was we looked at everybody that we have in clinic. So out of the 140-ish people that we've seen at the time, I think it was about 130, we had 75 people that we were following specifically for their seizures, not just that we had seen once or that maybe had the occasional seizure, but 75 that we were actually managing for ongoing seizures. And so they were all seen multiple times, and we were actually following them. And what we found was that this may be a little bit confusing, but if you kind of look at all the way right to the greater than 90% improved, so the ones that had either full seizure control or near full seizure control, as expected, those on valproic acid or Depakote actually had a pretty good response. But we saw even better responses to levetiracetam, which is Keppra, lamotrigine, which is Lamictal, and clobazam, which in the U.S. now is called Onfi, is the brand name. And so, slightly better percentages, but somewhere in the same ballpark as far as how well they work. And another thing that we use a lot here at Mass General is the low glycemic index treatment. It's a special diet we use for seizures that we've had luck with Angelman syndrome. And but this is the more important thing, is what we found was that about 2/3 of those on Depakote reported adverse side effects, which is something we see a lot. Depakote can actually cause issues with balance, and it can cause tremor. And so when you have a population of kids and adults who have balance and tremor issues to start with, it often makes things worse. And so we had a lot of people who were just more shaky, more tremulous, had more trouble ambulating. So that's one of the biggest reasons to get kids off of medicine. Beyond that, you can see a lot of weight gain, and you constantly have to check liver tests, blood counts, that sort of thing. Whereas with levetiracetam, it was only about a 20% adverse effects, which is what we see in the general epilepsy population. With Keppra, about 20% will get miserable, cranky, irritable, angry, and that's kind of what everyone thinks when they hear Keppra, but really it's only about 1 out of every 5 people. It's not universal, it's not everybody, it's about 20%, and we found the same exact number in our folks, about 20%. Lamictal is about 23%, and it was a typical Lamictal side effect. So sometimes you get a little bit activated, so it's kind of harder to sleep, you can get a little bit agitated. Rarely you can get a rash, but kind of mild side effects. And with clobazam, it was about a little under 1/3 had side effects from it. A great medicine, but about 1/3 of kids and adults will get sleepy. That's the one big side effect that you can get with clobazam. So similar to the survey of 2009, what we found was that the newer medicines like Keppra-Lamictal were similar to valproic acid in terms of how well they work. Clobazam wasn't really widely used in 2009 because it wasn't available in the U.S. It became available, I think, in 2010, 2011. So we didn't really have any good data on it, but what we're seeing now is that it really is effective, and it's probably the medication I use more than any other in folks with Angelman syndrome. But in the data we're kind of looking at now, just in our clinic, it seems to be as effective as Keppra and Lamictal. And similar to 2009, valproic acid had much higher rates of side effects. We saw that in the survey back from 2009 as well. So moving on to myoclonus.
So in our study looking at adults, there were 5 individuals whose caregiver described that the individual was having a prolonged period of shaking. So myoclonus or myoclonic event is a shaking event or a jerk-like action. And parents were describing that individuals for a period of minutes to hours might have a discrete period of time where they were shaking in one or more limbs or throughout their body. And that initiated some additional study and for us to sort of think about that as a area of interest and thing that's potentially affecting adults. So myoclonic seizures, as you know, are common in Angelman syndrome, about 40%. These are very brief in duration, and they're often affecting children, usually seconds to minutes. And individuals who are having myoclonic seizures will have a very specific finding on their EEG, both while they're having the seizure as well as in between seizures, so ictal and interictal. Myoclonic status would be sort of when you have a prolonged period of myoclonic seizures, and in that state an individual would be unresponsive or might have very decreased responsiveness or loss of skill specifically, and that happens in individuals with Angelman syndrome, but we believe more frequently and almost exclusively in children. We also are looking at non-epileptic myoclonus, which we believe is likely what we are seeing in the interview series of adults, where they're having this prolonged period up to hours or multiple times per day, where there is no significant alteration in consciousness. They might continue to be active, they might continue to eat or walk without a significant loss of skill. Parents describe that sometimes an individual might show a change in their face, sort of indicating to us that they might be feeling some pain or discomfort while it's happening. The key, though, is during these events, when they're captured on EEG, they typically don't show those characteristic changes that we see with myoclonic seizures. And so we've moved forward to further study these non-epileptic myoclonus because the impact for any given individual can be quite significant, really affecting quality of life and ability to participate in their normal activities, and we don't know sort of what the actual experience is like, but potentially, as I mentioned, there's some element of fear or some element of discomfort happening while it's going on. And so we want to see what we can to sort of further understand it and potentially treat it. So within the clinical cohort here, there were 18 individuals who have been diagnosed with and we suspect to have non-epileptic myoclonus. In this cohort, it was seen across genotypic subtypes, and we had 7 individuals who had EEGs, 2 of which were done here and 5 of which were done at outside institutions. But the bottom line is that when these events are happening and an EEG is done, typically there's not that same characteristic change that you see with myoclonic seizures. We as I mentioned, are continuing to study it. When we look at the 45 individuals in the clinic who are 13 years of age and older, 40% of those were found to have non-epileptic myoclonus. Within this group, it seems to be a little bit bimodal, where 7 individuals had onset between the ages of 11 and 15, and then 11 had later age of onset. And as we continue to follow this adolescent adult patient population, we're continuing to learn more about sort of how it initially presents and how we can recognize it more efficiently. In the older events, or in the older individuals, we believe that they may in fact be having longer events, but again, we're continuing to study that actively. As you can see from this slide, the prevalence as you increase in age, the prevalence of this finding is also increasing.
Yep. And so the other thing that kind of differentiates myoclonic seizures from these kind of non-epileptic myoclonic events is response to medicine. And so you kind of saw the numbers earlier with their general responses to Keppra, clobazam, Lamictal, those kind of medicines. You know, we've had pretty good luck treating seizures in kids and adults, but these non-epileptic events have been really hard to treat. So the 3 medicines that we've used the most and that really work the best so far that we've found, there may be others, but you know, we've tried a bunch, and these are the ones that tend to work the best. So Keppra, or levetiracetam, tried in 10 of the individuals, and about 30%, or actually exactly 30%, had significant improvement. 20% were noticeably improved, but somewhere between 50 or 90% better. And then, but half of the people didn't get any better at all on Keppra, and the numbers were pretty similar for clobazam or Onfi. About half of the folks didn't get better, and in fact, two of the 9 couldn't really even get to high doses because there was fatigue from the medication. So really, only 20% had significant improvement, 10% had decent improvement, and then with clonazepam, which we don't use as much for seizures anymore because it's typically more sedating. We actually had pretty decent luck with that one. Out of the 5 people, 2 of the 5 had really nice response, 2 of the 5 had a pretty good response, and then 1 of the 5 became fatigued. So, those out of all the things that we treat with in Angelman syndrome, at least all the brain-related things, this is one of, if not the most frustrating to treat, because it just doesn't respond as well to medications as other things like seizures and sleep and other issues can respond. So speaking of sleep, sleep problems, so they're described in the diagnostic criteria that Dr. Williams and his group had put out in 2005 as abnormal sleep-wake cycles and diminished need for sleep, listed as 20 to 80%, with diminished need for sleep being, I mean, they appear to not need sleep, but really everybody needs sleep. Caregiver reports in the literature range from anywhere from 40 to 80% of people with Angelman syndrome having sleep issues, and what we've seen in other studies is that sleep issues are more common in children with AS than in other healthy kids with non-AS related developmental disabilities. So sleep problems are likely multifactorial, and one of the theories that we have is that it may be related to the abnormal GABA transmission. So there are receptors for the chemical GABA in that 15q region that are deleted or not turned on in most, and GABA really plays an important role in sleep, as it does in seizures and it does in anxiety. So it's really, I think, one of the big chemicals that that causes a lot of these neurological issues. But other factors that could play a role in sleep are seizures. So not only do seizures cause sleep dysfunction, but some of the medicines we use will cause problems with sleep. GI symptoms like constipation and reflux can wake people up in the middle of the night, especially when you're laying flat. And then anxiety, some people just really have trouble sleeping because they're anxious. So as far as sleep medications, there's been limited studies to look at sleep in Angelman syndrome. Melatonin is typically first line, and there have been a couple of small case series saying that it's effective, and for a lot of people it is, so that's usually the one we go to first. But when that fails, then you have to go to kind of that next step of sleep medicines, and really anecdotally, people have had some luck with is trazodone. Benzodiazepines like clonazepam or clobazam. Gabapentin, which is called Neurontin, is the brand name. It can be helpful sometimes. It's in that same GABA spectrum. And just helping to fall asleep, clonidine can be useful. So again, no great proof, no great studies done on all this stuff, but just anecdotally, this is what we've had some success with and what other people have had some success with as well. And when we did the seizure survey back in 2009, we also did a sleep component to kind of look at sleep and seizures together, how they kind of interacted. And what we found was that about 80% of people had tried at least one sleep medicine, with the most common being melatonin, second most common being Benadryl, followed by small amounts of lots of other medicines. So clonidine is one of them, but then all sorts of different things were tried. And then moving on to our adult study.
So in the adult study, we sort of were interested in what happens to individuals as they age and their sleep. And some of the knowledge that we've sort of always heard and thought about is that potentially sleep improves with age. And to some extent we found that. However, we did recognize that sleep problems were seen in 72% of adults, adolescents and adults that were included in this study. And so it definitely had a very, very high prevalence, and it was one of the major issues that individuals were describing as a challenge on a daily basis in caring for an individual with Angelman syndrome. 22% were on melatonin, and a quarter of the cohort were also on an alternative medication, as Dr. Thieberg described. We think about the quantity of sleep that individuals are getting. This is a very difficult metric to get out of sort of a interview series style study, but we're interested in sort of understanding how much an individual is sleeping. And the average was reported per night at 7.4 hours. This, I think, is also very interesting and potentially can provide some hope to parents of younger children. When caregivers of adults were asked how is their son or daughter sleep now compared to infancy, the majority described it as improved compared to when their son or daughter was a baby. And then also when compared to childhood, adulthood sleep is improved compared to childhood. So there is significant improvement potentially throughout an individual's life. However, it remains a primary area of concern for the majority of individuals. So when we think about sleep, we think about sort of several different categories of problematic sleep or difficulty with sleep. We think about sleep latency, or the amount of time it takes an individual to fall asleep, or the difficulty with which it is to fall asleep, and 65% describe this as a major issue, half of which requiring TV on while they're trying to fall asleep as sort of a helpful measure or a thing that they sort of need to do to help them fall asleep. And then we think about night wakening or difficulty staying asleep as a second area of concern when we think about sleep. Overnight waking was very, very common, and for an individual to be up for many hours with relative frequency throughout the cohort. Additionally, we think about sort of additional measures that families are doing to sort of cope with night wakening, and that might be having the TV on all night, or needing to have some form of co-sleeping or close nighttime monitoring. And so this might be having a caregiver in the room or using a video or audio monitor. Additionally, we think about daytime sleepiness as a index of some challenging sleep, and that was also quite common. So we also looked at GI issues in adults with AS. Many of you know this is additionally a very interesting and important area to sort of learn more about. We think about decreased satiety, and it's a difficult one to sort of really have a strong sense of, but the satiety or having a sense of fullness. Half of caregivers described that they as caregivers needed to sort of help regulate how much the individual was eating because they felt that that individual wasn't necessarily going to do that regulation on their own. Additionally, poor hydration or it being pretty difficult to the individual hydrated for one reason or another, behavioral or otherwise. They had some resistance to drinking fluids. Gastroesophageal reflux as a major issue in childhood, but continues in about half the cohort as into adulthood to some degree or another. Additionally to requiring medication for a subset of that group. We also think about cyclic vomiting and the sort of etiology of that and why that's happening can vary based on the individual, we believe, but it's not uncommon in this adult group. And then constipation was really almost universal within the study group. Many requiring medication for treatment. And so that being an area of clinical monitoring within GI issues was seen to be quite important. We also think about anthropometrics, or if an individual is under or over their goal weight. And as you know, this is a very complex issue with multiple factors at play. We think about potentially a genetic predisposition, and as I mentioned, potentially an aberrant sense of satiety or feelings of fullness. As you know, limited access to opportunities for exercise can be a major player in this case, and then also challenging behaviors related to food, or food being one of the only sort of effective reward systems that an individual might respond to. And so we believe that sort of there's potentially a shift that happens between childhood and adulthood, where you have a decrease in the number of individuals who are underweight and an increase in those that are overweight or obese. We had increased odds of women in our cohort having obesity, and interestingly, we also did not see any specific genetic subgroup as having an increased risk of obesity.
And then so just to kind of follow up on that, we're doing a study now. Actually, it's pretty much done. We just have to kind of finish it up and submit it for publication. But looking at GI issues in folks with Angelman syndrome with all ages. And so it was our clinic here at Mass General, but we also, it's the first study that we've done in combination with our sister clinic at North Carolina. So at the time of the study, we'd seen 120 patients. This was a few months ago, and then the folks in Carolina had seen 43 so far, so total about 163 people altogether. And the genetic breakdown was pretty, at both sites, pretty equal in terms of deletions, UPD, UP3A. It was, and really basically kind of representative of the general Angelman population. We had a nice range, ours from age 1 to 42, and theirs from age 1 to 33. Our mean age was a little bit higher, about 13 years, and for them it's about 9 years. And gender-wise, pretty equal male to female. And so what we found was that 86.5% of all families had reported some GI symptoms, so kind of as we expected, a very high number, with the majority being constipation. So about 72% reported constipation, 44% reported reflux, and almost 10% had reported like a cyclic vomiting type of spell where people would kind of vomit frequently and that would kind of come and go. And then so the endoscopy numbers that's out of 120, that's just we only had endoscopy data, but about four of the 120 had endoscopies and had confirmed eosinophilic esophagitis. About 5% had trouble swallowing. 2 out of the 120 had excessive swallowing, and 10 out of the 120 that we've seen here had a swallow study. So what was interesting was that the constipation and the reflux rates didn't differ significantly amongst genetic subtypes. So whether people had deletions or mutations or UPD, there's just lots of constipation, lots of reflux amongst everybody. But those that had poor feeding as an infant, that was really only in those with deletions, or the vast majority only had deletions, and the people that required G-tubes were only in those with deletions. So kind of the people that had maternal deletions tend to have the poor infantile feeding and at some point the need for a G-tube. Whereas those that had deletions or UPD were the only ones that reported the difficulty swallowing, the excessive swallowing, or the eosinophilic esophagitis. So, so in the case of the more kind of the less common, more severe type GI side effects. Those were in folks with deletions, and in terms of the swallowing issues, also with UPD. But as far as just plain constipation reflux, that was pretty consistent throughout. Okay, and now on to orthopedics.
So we also looked at orthopedic issues in our interview series. We asked caregivers about knee contracture or tightness at the knee, and that was not uncommon at 43%. We also asked about what proportion of the group had had a tendon lengthening surgery in their history, and about 20% had had that. Think about scoliosis over the lifetime and wanted to understand that further. About 50% of the cohort had a diagnosis of scoliosis. The average age at which they were diagnosed with scoliosis was 12 years of age. We look at the breakdown of the cases with scoliosis to understand a little bit more sort of what happens over time. Of the 54 individuals who'd been diagnosed, 61 were reported by caregiver as having mild scoliosis, and 40% as severe. When we look at surgical intervention, 24% had had surgery ultimately for their scoliosis. We didn't see a significant difference in rates of scoliosis when correlated with indices of mobility, interestingly. Additionally, we think about bone health, osteoporosis and osteopenia. This is an area of bone density, and we had 16% who had been diagnosed at one point with osteoporosis or osteopenia. It's my sense that there is increasing understanding of this in the cohort, and that this proportion is somewhat reflective of the limited number of individuals who'd had a DEXA scan or had actually had inquiry into their bone density. And 7% had had a fracture of a long bone, specifically of their hip or of their femur, a pretty relatively high proportion. Additionally, we sort of think about why individuals might have decreased bone density, and potentially it has multifactorial, thinking about relatively limited mobility over their lifetime, potentially, and or chronic AED treatment, putting them at increased risk for decreased bone density. So when we sort of think about orthopedics as an area of interest for individuals with AS, you want to sort of keep in mind scoliosis, contractures, and fractures. We also looked at mobility. This is a very interesting area, I think. One of the very hopeful statistics from this study, I believe, is walking independently was 68% of the cohort. You think of a sidearm assist or with someone there with them at 22%, and truly non-ambulatory at only 4%. When we think about that 68% of individuals who are walking independently, we also think about each in the settings in which they're doing so, in the home and in the community. So the vast majority are walking in their home. But then when we go to the community, as many of you know, walking and sort of being able to walk on your own is much more limited. I think both contributing to that decrease from 39% to from 93%, excuse me, to 38%. Contributing is behavior as well as sort of safety concerns. To keeping the individual safe, they might not be walking in the community at the same rates as they are in their home. We also think about how far they're walking, and only about a quarter are walking with no limit to the distance that they can go, and a greater proportion, 41%, actually have a relatively limited maximal distance. And the reason they're not walking further is, again, it could be contributed to by behavior based on sort of caregiver impression. They don't want to walk further, or physical symptoms or suspected pain symptoms. Many individuals are active and exercise in a lot of different ways with adaptive bikes and swimming in pools, doing yoga and stretching. We're all also reported as happening individually. Very exciting to see new innovative ways of exercise. We think about challenging behaviors. This was a major area of interest of mine, and we discussed really very extensively throughout the interview, thinking about and incorporating our understanding of challenging behaviors in Angelman syndrome. We found in this group 72% had behaviors that could be consistent with aggression towards others. It's important to sort of think about that number as it is. So the majority of you very well know that the aggression or a behavior that has the potential to harm others is typically not of malicious intent, but rather an attempt for social interaction, hair pulling to draw someone's attention, for example, or arm pulling in excitement or in an attempt to interact with someone that you may not know. We also saw just over half had behaviors described as consistent with self-injury. Interestingly, we also had many individuals describing behaviors that had a quality that included an obsessive or perseverant element, so potentially a deviation from a typical routine could trigger a behavior, or a ritualistic behavior that someone really focuses on routinely as contributing to challenging behavior. We also talked to caregivers about specific emotional triggers, and we saw that, you know, as predicted, 20% or a significant proportion were contributed to by anxiety, we believe, as well as frustration. So one area of this study that we actually won't cover significantly today is communication, but that communication plays an incredibly important role in our understanding of challenging behaviors, and I believe that frustration statistic is typically in relation to communication. So these will look familiar to many of you, pulling others' hair, hitting others, yelling, screaming, pulling on others. We ranked the most frequently reported behaviors to try to sort of understand them a little bit more. And I won't go through them, but as you can see, they are inclusive of behaviors that can result in social isolation, some that result in aggression towards others, and many that are related to self-injury. So as I mentioned, we sort of think about triggers, and routine was a major issue. Sensitivity to change in routine in relation to challenging behavior was described by 50% of people in the study, and a consistent routine daily was described by the majority of individuals. As we sort of take a step back, when thinking of challenging behaviors, they're so individual and so complex, contributed to by so many different factors. When we think about what are we going to do to help individuals develop additional coping skills and to help them with their behaviors, we think about reward structure, and the majority, 55%, describe that immediate reward can be effective, but very few describe the delayed reward technique as being helpful. Also, we wanted to understand if people were receiving any medication in their home institution for that have had an impact on their challenging behavior. And we wanted to do a comparison of what individuals had been on in the past and what they might be on currently to give a sense of what may have been effective. So as you can see, that previously in the past almost 20% has been on antipsychotic medication, but now currently only 10%, sort of decreased use of that category of medication. Additionally, decreased use of stimulants and antihypnotics. However, a relatively stable and increasing use of SSRIs, anxiolytic medications, or medications that typically are helpful in the setting of anxiety. So the majority of individuals in this cohort had not been evaluated formally by a psychiatrist, but 46% of caregivers described that the individual showed some signs of anxiety. And then alternatively, only 2% endorsed possible signs of depression.
Yeah, and so kind of going on just what we see in our clinic. So we don't really have any good clinical data, and there's really nothing in the literature. So that's something we're hoping to try to change at some point in the near future. But what we see in our adults is that more than not have signs of clinical anxiety, and really I think most do. And so often this is severe and can be a significant quality of life issue. So really, I think a lot of the behaviors in Angelman syndrome, from kids all the way up, I think it gets worse around puberty, and then really kind of really gets a lot worse in adulthood. It's really anxiety driven, and so a lot of times you'll see people on antipsychotics, they'll be on Risperidone, they'll be on Abilify, and those are kind of the medicines that are they're kind of FDA approved to be used for autism and for the behaviors associated with autism. But those are different from what we see in Angelman syndrome. And people with kind of classic autism, they are more irritable, they're more aggressive, and those are kind of what those treat. But in Angelman syndrome, I think it's really more of a pure anxiety, and so those drugs tend to work because they sedate people, and that's, so it's going to work for anything more or less. But it's not really getting to the root of the issue, and I think the root of the issue is anxiety. And again, I was saying a big piece of that is not being able to communicate. But I think part of it too is just chemical. I think just with the abnormal GABA transmission, people they just get more anxious, and so that's why a lot of the times we'll use medication like benzodiazepines. So anxiety is interesting in Angelman syndrome. In some people, it's pretty obvious. They just seem nervous, but in others, they'll refuse to leave the house. One of the big things we see in adults is clinging to their caregivers. So they'll not want to just have mom out of the room or dad out of the room. Sometimes they just get mad if mom or dad talks to somebody else. So they get there's a lot more kind of clinging to parents or caregivers as they get older. And like I said, some people don't want to leave the house, and sometimes it's even looks medical. It can mimic GI issues like excessive swallowing or vomiting. You wonder how many of those people that have this cyclic vomiting are actually having anxiety. And even with the orthopedic folks, the percent that won't get up and walk when they go in the community, it's probably not so much about mobility as it is about anxiety. So it can present as looking like orthopedic, it can look like GI, it can look sometimes even seizure-like. But I think these are all atypical presentations of anxiety, and there's really no data on medications for anxiety anywhere. Just kind of anecdotally, we've used benzos. So one of our favorites is clobazam, which we use for seizures, but because it's in that kind of benzodiazepine family, works on GABA, can be really helpful for anxiety. Actually, any of the benzos can. That's the one that's usually best tolerated, but Klonopin, Ativan, Valium can be helpful. And then we put a few people on Buspar as well, which is an older anxiolytic, but just kind of a pure anxiety medicine, which tends to work pretty well in some people with use. But again, we haven't really looked at it. That's something we're hoping to look at in the future, is what's the best way to fix this, because alongside of the kind of myoclonic tremors, the non-epileptic myoclonus, this I think is one of the hardest things that we have to treat. We're getting better at recognizing it, but then once you figure out what's going on, then the second step is like, how do you actually fix it, which is not as easy said as done. But kind of getting towards the end, I guess in summary, before we say our thank yous, we're seeing more and more adults with Angelman syndrome as, the first group of kids are now getting older and becoming adults. And I think what we tend to see on the positive is that seizures tend to get better. Even those that we do see having actual seizures as adults in clinic, they're typically one seizure in the past year, two seizures in the past year. It's, we're not seeing those, daily head drops, daily staring spells. Those tend to go away with puberty, which is great. So we're seeing actually better seizures in most. The ones that do often report tough seizures, those are often myoclonic, non-epileptic myoclonic episodes. So a lot of the seizures we're seeing in adults really aren't so much seizure, but not that that's easy to treat, but at least it's not as much of an emergency. It's not as dangerous as seizures. It's equally as disturbing to quality of life, but at least it's not seizure. From sleep, we still see sleep issues, but they tend to get better, which is great. What we do see get worse is anxiety, and that's one thing that's just not as well understood, and it's harder to treat, but at least we're seeing it more and recognizing it more and trying to treat it more. And then these myoclonic tremors that they can be really annoying are being seen more. And then I think just as far as the other stuff, the GI and the orthopedic stuff, just being able to just recognize it and acknowledge it, because a lot of adult providers won't think that. That's, as pediatricians, we always kind of think GI, like that's just kind of, we're trying to do that as neurologists. So we always think about the belly, we always think about the bones, but that maybe isn't something that adult providers are always aware of, so that can sometimes get missed. So that's just something else to think about as well.
So we wanted to thank you all so very much for joining us. For those of you who participated in the adult study, again, it's under pending review, and we just are so grateful for your participation. We're grateful to both Eileen and Sheila from the Angelman Syndrome Foundation, to Fred and Renee Pritzker, as well as Jacob Pritzker for their support of the study, and to Jane Summers for her help with our work in behavior.
And I think that's it from us, Sheila.
Perfect. Thank you, guys. We do have some questions that have come in, so I'll go ahead and try not to butcher a lot of the, the bigger words. The first one, somebody was at the CAS conference when you were talking to Dr. Siebert, and wants to know, you had talked about if an Angelman adult patient has not had seizures in over a period of time, that the medication should be adjusted. Apparently their neurologist does not agree and says that the medication he is now taking also controls his behavior. Are there any thoughts to that? And then they gave what the child was, or the adult was on as well. And
oh, yeah, well, so that's always a great question in terms of, and someone asked that as well, and it wasn't a family conference, but one of the people at the scientific conference in Cambridge had asked. So it's always a tough question when you have adults that have really well-controlled seizures, no seizures for years. What do you do with the medicines? And a lot of it depends on which medicine it is. So people don't always have to stay on medicine, and that's never an easy decision, because we've had so few adults in general. But then as far as people that have come off medicines, we just don't really know what the percentage is, how many will stay seizure-free, how many won't stay seizure-free. So typically what I do, at least the way I kind of approach it, if it's an older medicine like Depakote or Transine or phenobarbital, or like anything that I think is going to have long-term side effects and just overall not be good for people, I try to get people off that medicine. But what we have been seeing, though, is because we have so many adults with anxiety and we have so many adults with these myoclonic tremors, the folks that we're seeing who are on Depakote, whatnot, we're often putting them on Keppra, on clobazam, on Klonopin for either anxiety or for the non-epileptic myoclonus. So generally, when you get them on another medicine that can treat seizures, then they don't so much need the older medicine anymore. So it's a tough call. It's not that people have to come off medicine. It's just a question of, if you're on a medicine that may not be something you want to be on for a long time, it's usually worth trying to get rid of it. And so, people that are on either Keppra or Lamictal, there's really not a lot of downside to staying on those, because we know there's no long-term issues with liver, with bones, with blood counts. So it really depends what you're on. But people that are definitely on medicines that I worry about long-term, issues such as liver, bone health, whatnot, I do try to get people off. And whether it's just coming off altogether, or if parents are much more comfortable staying on something, we can switch to something that will either be better in the long term, or may treat something else like anxiety or tremor. But it's kind of nice that we have so many medicines that are these kind of 2-for-1 medicines. So even though clobazam is a seizure medicine, we use it a lot for anxiety. And if you prescribe for anxiety, the drug companies probably won't. I mean, the insurance companies probably won't approve it. But if it's someone who's had seizures and is on a seizure med, if you switch to clobazam as a seizure medicine, but really use it for anxiety, and that can be a nice kind of a nice switch. So you're really giving something to treat for anxiety, but also it's going to just kind of leave you covered for seizures just in case. If that makes sense.
okay. Can you tell us anything about carnitine and ammonia levels in adults which are related to tremors?
That's a good question. So not really. So the reason we check carnitine levels and ammonia levels, basically it's for people on Depakote. So you can get, your ammonia levels can get high in your blood and your carnitine levels can drop. And carnitine is an important Yeah, cofactor. Thank you, Ann. A important cofactor. So it's what kind of helps get your fat into the mitochondria to be used for energy. So without that, lethargy and whatnot. So Depakote will lower your carnitine stores and it can increase ammonia. So the question is that what causes the tremor, or is it the Depakote itself? It's hard to know, but definitely if you're on that medication, those have to be monitored, and definitely the carnitine has to be supplemented. So that's just something to kind of watch. But typically, even if the ammonia is normal and the carnitine is supplemented, it can still worsen tremors. That's just kind of what it does. That's just kind of a classic Depakote side effect, and it's not so bad in most people, but in people with Angelman syndrome who are a little bit tremorous to begin with and a little bit off balance to begin with, those side effects can really be magnified. So, yeah. If that makes sense.
Okay.
Mm-hmm.
Another question is, my daughter is on both clonidine and melatonin for sleep regulation, and they're thinking about discontinuing the clonidine under the supervision of their neurologist. Are there any long-term effects to the use of clonidine?
Not that we know of. Clonidine is really super safe, so it can be a little bit sedating, but if the dose that people are on isn't sedating and they don't wake up with any kind of hangover effect, it's really a very safe medicine, and there's that I know of, there's really no long-term worries for clonidine. It's actually one of the safer medicines we have, and a really good kind of falling asleep type medicine. And one of the nice things about clonidine too is that since it's not like a seizure medicine, it's a blood pressure medicine that's not great for blood pressure. So, but it's good for kind of making people tired. So it's not like a seizure medicine where you have to kind of ramp up slowly and get to that dose and then kind of taper off. You can just kind of start it, and it's not like cold turkey it, but you can go up on it fast and get off it fast if you want to. So if people ever come off it and the sleep isn't as good, you can just kind of go right back on it, and it's not a big deal usually.
All right. Can being dehydrated cause tremors?
It can definitely worsen tremors. So in people that are kind of prone to tremors, anything that's going to throw off your system could make them worse. So if you kind of baseline, if you're a little bit tremulous to start, dehydration is going to worsen them, fever is going to worsen them, poor sleep is going to worsen them. This is going to sound crazy, but constipation will worsen them. So one of the best treatments we have for these tremors is Miralax and Senecot. Really, anything that stresses out the system, and you can't underestimate the importance of sleeping well and not being constipated. Those things those will both worsen seizures, they'll worsen sleep, they'll worsen tremors.
Okay. Another question is, my son is 7 and is starting to experience increased anxiety issues. Mm-hmm. And then they say, no, it's illegal, but is high CBD cannabis oil even discussed as a possible treatment to balance cortisol levels?
It's a good question. As far as we know, no. The kind of the high CBD compounds that there's drug companies in England that are making them, and then you can get them in Colorado. But the cannabinoids, they act on actually cannabinoid receptors, and we think they're good for seizures. But as far as the other stuff, we really don't know what kind of effects it's going to have on anxiety. There's nothing that would tell us that it's going to be a good anxiolytic. We may find out in trials that maybe it does help, but that's not one of the anticipated benefits of it.
Okay. Sorry, trying to get through all these. Is there any safety issues or use for, is it imipramine?
Imipramine. That's I don't think so. I don't use it much. If I remember right, imipramine is a tricyclic. So I think it's pretty. I mean, I think the tricyclics can have. It's kind of in the same family as amitriptyline, if I remember right. So you can get some like anticholinergic type activity, but in general, it's usually pretty safe and pretty well tolerated. You can't combine it with some other medicines. You can't combine it, I don't think, with like SSRIs. I think if you put the two together, you can have some side effects. So it's one of those things where you have to kind of watch out what you use it with. And there's some potential for side effects, but in general, I don't think it's a big issue. It's just not something I use personally, so I don't remember exactly. But if I remember right, it's it's a tricyclic, but a pretty safe one, and so you might get some. You can also get the same kind of side effects you get from way too much Benadryl, um, but yeah, I think with those you just have to be careful what you combine them with. But since I don't use it, I don't remember off the top of my head everything.
Okay, just a couple more questions. One is, for the study, did you look at sexuality at all?
We looked at, so for our challenging behavior section, we looked at sort of talking to families and having them provide the list of behaviors that were of challenge to a given individual. And in that respect, masturbation was described by 3 or 4 individuals, it sounds, I believe, so it was not one of our sort of most highly ranking, significantly challenging behaviors for the cohort. Additionally, we looked at age at menstruation and sort of the use of any sort of hormone therapy to sort of regulate periods for women, and the age at menstruation was not significantly different from the general population. But sort of beyond those 2 parameters, we didn't look at sexuality more than that.
Yeah, and in clinic it doesn't come up a lot as, when you, I don't ask about it specifically, but when we ask about things that are worrisome or are concerns, that never really comes up much. But certainly in the general autism population, just I see folks who just idiopathic autism. Well, that does come up sometimes, and unfortunately, it's a hard thing to deal with. There's really, like Dr. McDougall says, who runs the Laurie Center here, who's a national expert in autism. He says that they have the same kind of thoughts and desires as everybody else, but not the social awareness to kind of control when they act on them, and so it's a tough thing to deal with. Luckily, it doesn't come up that much. Luckily that we've seen. So I don't know if people are just not wanting to talk about it, or if it really just isn't that big an issue. But it's a great question though. It's just something that I never bring up specifically, but in clinic it rarely comes up. In the survey, it was really just a couple of people that mentioned it.
Okay. Are you finding a loss of mobility or endurance in adults coinciding with abnormal EEGs?
That's a great question. So luckily we don't have too many adults that have a lot of tough seizures. My guess would be yes, if the EEG was very abnormal, it would make mobility more difficult. Like I said, luckily we haven't seen that. We've been pretty lucky with pretty good seizure control for adults, but I would expect decreased mobility with a bad EEG and increased seizure activity, definitely, because we know that in kids who have non-convulsive status and frequent seizures, their motor milestones are delayed, and when you can control their seizures and really kind of make the EEG better, you can see pretty rapid developmental progression. So definitely, the fewer seizures, the better for mobility at any age.
All right, we'll just do a couple more questions because I want to respect your guys' time. One of them is, what can we do to lower the ammonia levels?
Well, my favorite thing is stop the Depakote, but that's that's just I have kind of an anti-Depakote thought. But if it's something that's really working and people are going to need to stay on it, there is a medicine. Is it lactulose? I think it. Oh boy, there is a medicine. I want to say it's lactulose, but there is a medicine you can give to lower ammonia. Typically, I will just stop Depakote if the ammonia is high. But if it's something where the ammonia is kind of slightly elevated, and I don't want to be 100% quoted, but there is a medicine that will help lower ammonia levels, and I'm pretty sure it's lactulose. But definitely, if that's the case, hopefully the doctor that ordered the test will be able to address that. But there is a medicine, but ideally, if the ammonia level is high, usually the best thing is just to come off and switch medicine.
All right, and then last question: have you ever heard of, I think it's Lupron injections being used to help with aggression due to high testosterone?
Good question. So for just plain old aggression for no good reason in general, no. But if there really is a hormonal imbalance, then sometimes, yeah, Lupron is a medicine that I don't use because it's really only the endocrinologists use it. It's an endocrine medicine, but if there are behavior issues that come from hormonal imbalances, sometimes treating the hormonal imbalances will treat the behaviors. So Lupron, I don't think Lupron is used specifically for aggression, but if Lupron is being used to treat the hormonal imbalances as a nice bonus, that usually improves behavior.
All right, perfect. And if you guys don't mind, I'll send you some of the other questions that we didn't have time to get to, and then
is it a bunch or just a couple?
Yeah, if you have time to answer them, that would be awesome. And again, for all the attendees, this was recorded and it'll be up on our YouTube channel and our GoToMeeting channel probably in the next couple of days. So thank you, Dr. Larson and Dr. Hebert, for joining us today, and it was great. Thank you. Have a great night.
Thanks, Sheila.
Thanks so much.
You're welcome.